NTW would not be possible without the support of outstanding medical leads who give their time to present and develop each session, collaboration with professional bodies and sponsorship from organisations. And today we're really pleased to start our first sponsored symposium by Cardinal Health. So without any more ado, let me introduce you. I'd like to introduce you to Loizos. I'm going to say the surname incorrectly now. Loizos Georgiou is a VTE prevention clinical nurse specialist at Princess Royal University Hospital and South Sites. Loizos joined King's thrombosis team initially as a DVT and coagulation nurse specialist in June 2018 and became the VTE prevention clinical nurse specialist for Princess Royal University Hospital and the South Sites in December 2018. And today in the sponsored Cardinal Health session, he's going to be discussing improving VTE practice based on experience. So I welcome you and pass over to you. Do you want to share your screen?
Thank you very much for the introduction, Joe. Let me just share the screen. Brilliant, and I hope everyone can see that. So thank you again for the introduction, Joe. Good afternoon, everyone. My name is Loizos, and as Joe said, I am one of the VTE prevention clinical nurse specialists for King's College Hospital Trust. And I would like to thank Cardinal Health for sponsoring this symposium and Thrombosis UK for inviting me to this conference today. And a big congratulations to everyone for an amazing job and for organizing this. In this presentation, I will go back to some of the basics of VTE prevention and discuss the logic behind the need of protecting all adults, especially during their hospital admission, from developing clots. The National Institute for Health and Care Excellence and the national quality requirement remains that acute providers in the United Kingdom must undertake VTE risk assessments for at least 95% of service users each month, so to reduce the risk of hospital-acquired VTE episodes for all adult admissions. Venous thromboembolism is a significant problem for surgical and medical hospitalized people, leading to the possibility of serious illness and the risk of death. A hospital-acquired thromboembolism, or a HAT as we call it, covers all VTE events that occur in the hospital and within 90 days from discharge. About 1 in 4 people will die from causes related to a blood clot. More than half the VTE cases we see take place during or following a hospital admission, and it is considered the leading cause of preventable deaths in hospitals. And in addition to this, it has long-term financial consequences for both the patients and the health services. You can find more details on thrombosis statistics on the official page of Thrombosis UK. I'm sure that by now everyone knows that VTE stands for venous thromboembolism, which is an umbrella term we use when referring to any deep vein thrombosis or pulmonary embolism. Further down, we will go through real-life scenarios, scenarios that we got across from different areas and trusts of people that developed a potentially preventable VTE event during their hospital admission or after they were discharged from the hospital. And we will see how these events help us understand and improve our everyday practice on VTE prevention, and how related are with the NICE guidelines and national quality requirements and our local protocols as well. And starting with the first scenario, So we came across a 67-year-old female. They were admitted to the hospital with complex partial seizures with a background of glioblastoma. A CT head was performed and no acute hemorrhage was identified. A VTE risk assessment was not completed while an inpatient, and chemical thromboprophylaxis was not prescribed, was not offered to this patient. They stayed in the hospital for 9 days before being discharged back home. So here we have lack of VTE risk assessment, and we have 9 missed opportunities for thromboprophylaxis. 25 days from discharge, they returned to the GP and were referred to their local DVT services with acute leg symptoms and were diagnosed with left leg proximal DVT. Here is where some may say other provoking factors could potentially contribute to this event, like active cancer, age, reduced mobility, and potentially other comorbidities. And yes, indeed. And there have been a lot of studies, clinical trials, meta-analysis, and a lot of professionals who devoted a lot of time and effort to create, agree on, and publish all these guidelines and protocols for the correct and timely assessment and appropriate use of thromboprophylaxis for adult patients during hospitalization. All these factors mentioned are included in the initial VTE risk assessment forms and should be taken into consideration when completing the VTE risk assessment for identifying patients who should receive chemical thromboprophylaxis. Whenever we come across any similar case of hospital-associated thrombosis, we assess them as potentially preventable. Because if a VTE risk assessment was completed on admission, and if the correct chemical thromboprophylaxis was offered according to evidence-based practice, this event, the development of a clot in the leg for this patient, could have been prevented. According to NICE guidelines, all patients admitted to the hospital should be assessed to identify their risk of VTE and their risk of bleeding. The VTE risk assessment should be completed as soon as possible after the admission to the hospital or by the time of the first consultant review. Some trusts have an electronic VTE risk assessment set, and this makes it easier when we want to collect data regarding the overall performance. But some areas are still using paper charts. But I'm sure that this will change eventually as we are in a rapidly developed era. So the way a VTE risk assessment is completed, either electronic or paper, is not having any effect on the patient's treatment as long as it will be completed correctly and on time. At King's, we are fortunate to have electronic VTE risk assessment established for the majority of the inpatient areas, with electronic prompts to remind clinicians of the completion of a VTE risk assessment for their areas. Our thrombosis team, in cooperation with Business Intelligence Unit, has created patients and applications like ward view and alerts where professionals like ward managers and doctors can view the progress of VTE risk assessments in their areas daily. We are also organizing meetings and teachings and induction programs for all the new starters in our trust and updating them on the NICE and trust guidelines on VTE prevention, although COVID restriction slow us, unfortunately, a bit down. So we always make sure to highlight that we don't see the completion of a VTE risk assessment as a paper exercise only for meeting a contract requirement, but we are trying to preserve our clinical values and set a clear standard of what our patients should expect from us. At this point, I would like to say that at King's, we do produce and collect data, and we are managing to overcome the national target of 95% for the last 8 years. Moving to the second scenario, an 80-year-old female was admitted to the hospital with vomiting and diarrhea. They had a positive PR examination on admission with no changes in their HB and a background of hemorrhoids. A VTE risk assessment was completed on admission, and they were assessed as high risk for bleeding. So no chemical prophylaxis was offered to this patient. No further reports of any blood loss during their admission, and no VTE risk reassessment was completed. They stayed in the hospital for 8 days before being discharged back home. 34 days after discharge, they visited their local emergency department with increased shortness of breath, and they were diagnosed with pulmonary embolism. So, NICE guidelines recommend to reassess for the risk of VTE and the risk of bleeding all patients at the point of consultant review or if their clinical condition changes. At King's, we also advise for patients that initially were assessed as high risk for bleeding to review the bleeding risk on daily ward rounds and chemical prophylaxis to be initiated, to be prescribed as soon as it is safe to do so. As we discussed in the previous scenario, it is difficult enough to collect data and try to bring everyone in line to complete the initial VTE risk assessment for their patients. Unfortunately, it's even more difficult to keep up and remind everyone of the need for a reassessment. We are in close communication with junior doctors, consultants, ward managers, and matrons regarding the importance of patient VTE risk reassessment, especially within areas with high bleeding risk patients like neurosurgery, stroke, and trauma areas. Moving to the third scenario, a 79-year-old male was admitted to the hospital with worsening shortness of breath, chest pain, and vertigo. They were diagnosed and treated with acute coronary syndrome. A VTE risk assessment was completed on admission, and they were assessed as high risk of VTE and low risk of bleeding. Low molecular weight heparin was prescribed as indicated, but 7 consecutive doses of the chemical prophylaxis were omitted as refused by the patient. 23 days from admission, and while still an inpatient, they were diagnosed with pulmonary embolism. So guidelines suggest that on admission to the hospital, we need to make sure that people understand why they are having a VTE risk assessment and why they are offered thromboprophylaxis. If they have the capacity, explain to them the indication for the use of thromboprophylaxis, clarify any misconceptions they may have, and provide them or their carers with written and verbal information. Provision of VTE patient information leaflets is one of the national recommendations and is a way to increase people's awareness on VTE prevention and VTE signs and symptoms, especially when they are admitted to the hospital and immediately after their discharge. Here, I would like to say that it is also the third recommendation that comes from the second survey of the GIRF, of Get It Right First Time report, looking at people, patient level data of over 9,000 patients, and there is still a need to improve provision of written and verbal information regarding VTE risk. The survey showed that from those 9,000 patients, only 1/3 were getting any written information about their VTE, about their risk of VTE whilst in the hospital. So we see that the importance of giving the correct information to all the patients and their carers. A lot of projects are currently running nationally on the improvement of the VTE information provision to increase people's awareness and knowledge around VTE, which may in turn empower them to reduce their own risk of VTE and motivate them to discuss with healthcare professionals what strategies or methods are being used to minimize their risk of VTE, especially whilst in the hospital. Hard copy leaflets are produced and should be given to all patients or their carers during their admission to the hospital and before discharge. Links to web pages with easy access for everyone that wants to get some more information. Small videos and presentations on different free access platforms have been produced and released by Thrombosis UK as well. In cooperation with pharmacy teams, we are including, and while we're celebrating the National Thrombosis Week, we are including a Thrombosis UK clot check card. I've got it here with me today. And we're including that with every TDA bag, trying to provide some additional information to our patients on discharge. Going to the fourth scenario, a 77-year-old female was admitted with an acute left facial drop, diagnosed and treated with right-sided thalamic infarct. VTE risk assessment was completed on admission and assessed as high risk for VTE and high risk for bleeding. Chemical throat prophylaxis was not prescribed as is not appropriate for acute stroke patients. Mechanical throat prophylaxis, in this case, we're talking about IPC, intermediate pneumatic compression devices, was recommended but was not prescribed or applied. Weakness in the left upper and lower limb present, so we have a patient with reduced mobility. They stayed in the hospital for 19 days and they readmitted to hospital 2 days from discharge, and they were diagnosed with pulmonary embolism. As I previously mentioned, other factors may be responsible for the event, but it remains a hospital-associated thrombosis. Mechanical prophylaxis, either anti-embolism stockings or intermediate pneumatic compression sleeves, need to be measured correctly before applied to the patients, as long as no other contraindications are present. Based on the CLOTS-1 trial, clots in legs or stockings after stroke trial, anti-embolism stockings are recommended for surgical patients, but not for medical patients, and completely contraindicated for stroke patients, as they have been found to be ineffective at reducing the risk of deep vein thrombosis in these patients and are associated with an increased risk of skin damage. In this scenario, in the IPC was appropriate and should have been applied within 3 days from the acute stroke diagnosis. We always need to make sure that the patients and their carers understand the use of mechanical prophylaxis and the appropriate duration of this. In our trust, we are teaching and encouraging nurses as well as doctors to prescribe, measure, and apply and observe correctly the use of any mechanical prophylaxis that should be used. And usually the sleeves will be applied immediately after admission to the stroke units. We also have the support from Cardinal Health and other healthcare service companies representatives, and together we do organize drop-in sessions, visual sessions, or study days, as we did at least before COVID, and hope we will be able to do this again soon for all healthcare professionals, to inform them and update them, among others, on the contraindications and the correct use of any form of mechanical prophylaxis. We're going now to our fifth scenario. And I think this is the last scenario as well. So we have a 74-year-old female that was admitted with shortness of breath and chest pain. They were diagnosed and treated with an infective exacerbation of COPD, and the VTE risk assessment was completed on admission and assessed as high risk for VTE and low risk for bleeding. Pharmacological prophylaxis, low weight molecular heparin was prescribed, but incorrect dose for patient's actual body weight. Patient weighed more than 100 kilos. So we have 4 missed opportunities for correct thromboprophylaxis before worsening of shortness of breath and diagnosed with pulmonary embolism as an inpatient. So NICE guidance do not make any specific recommendations regarding low molecular weight heparin dosing in weight extremes for people that weigh more than 100 kilos or less than 50 kilos. This, though, has increased the uncertainty of the optimal prophylactic dose of pharmacological prophylaxis in the population with extreme weights. In our trust, based on evidence-based data, local clinical reviews, and the inverse correlation between anti-10A levels and body weight, and taking all of the information collected into account, a pragmatic approach for the VTE prophylaxis dosing in the weight extremes has been adopted. So when providing teaching to new starters or joining update days and meetings with nurses or doctors, we always make sure that they are familiar with the trust guidelines regarding chemical thromboprophylaxis prescription. Chemical thromboprophylaxis is always prescribed according to patient's actual body weight and kidney function. Nurses are taught to check for the weight, kidney function, and platelet count before administering the chemical prophylaxis. Doctors are always aware to look for a recently documented weight before prescribing. And if due to patient's condition, there is a difficulty to weight them on admission, then the most recent weight can be used. But whenever it's safe and appropriate, we advise for a new weight that must be documented, and those have to be adjusted if needed. We're fortunate enough to have pharmacy teams on board with that and involved in making sure that VTE risk assessments are completed correctly in advance before pharmacological prophylaxis prescription, and if the correct dose based on the correct weight has been prescribed. So closing down, would like to highlight that venous thromboembolism is a significant problem for hospitalized patients, leading to the possibility of serious illness and risk of death. Evidence-based guidelines help healthcare professionals identify people most at risk and describe interventions that can be used to reduce the risk of VTE. So despite the existence of evidence-based guidelines, the problem of VTE hospitalized patients persists, as we clearly can see from our scenarios and our everyday experience observation, as it is clear that evidence-based guidelines and recommendations are sometimes not fully engaged. On the other hand, the passive dissemination of guidelines is unlikely to improve VTE prophylaxis practice. The challenge of translating evidence into practice is a widespread problem across a range of healthcare settings and clinical problems. That's why we as professionals should not rest and should continue to produce research, local or national, to prevent deep vein thrombosis and pulmonary embolism and offer the best care for all our patients. Before I close, I would like to mention that King's College University Hospital was established as the first VTE exemplar center in the NHS in 2007, and we have been producing research on thrombosis and VTE since, and proudly providing a wide range of high-quality health services, which demonstrated a reduction in the number of hospital-acquired thrombosis and the number of those deemed preventable. So this is for me. I don't know if we have any questions.
Thank you so much, Loizos. That was fantastic. You raise a number of scenarios there and many challenges, and something that came to my mind, and I know there's some questions in on this as well, is it is often complex. So on each of your case stories, either the risk assessment was missed or the thromboprophylaxis was, or both. And it's sometimes complex to understand why they may have been omitted, because everybody's trying to do their best. Have you, within your trust, adopted any procedures to try to drive down into that data to understand what's causing some of those omissions?
We are currently running some data. We're currently going through some data and trying to see why there are some of those omissions. Usually we will find omissions because a patient was not in the ward during the time of the medication rounds, and that's something we're trying to highlight to everyone, that especially it's not just the chemicals from prophylaxis, it's all medication. If the patient went out from the area for a CT scan, for an X-ray, for some kind of another assessment, and they came back after 6 o'clock or after the medication watch round, we should still give them their medications. Unfortunately, we don't have a plan at the moment. We're still going through the data. We're still running the 2019, 2020, and 2021 data, trying to find the most common themes. And yes, the patient refusal is one of the most common themes as well. And I can see one of the questions now asking if there is anything else we can provide to the patients. Unfortunately, we can't provide tablets. The DOACs are not licensed as chemicals from prophylaxis during hospital admission, and there is nothing else that we could potentially offer to a patient that is refusing the chemical prophylaxis for their own reasons. The other thing we can offer them will be mobilization, early mobilization. Try to mobilize them as soon as possible and keep them well hydrated while they are in hospital. That's the only thing I can say about for that.
And obviously, well, I was watching a session earlier, and one thing that they'd found that really helped was they had implemented a handover of notes. During the handover time, they had to look at the medicine chart for the patients. Now, obviously, this is a huge burden when amongst a very busy teams. So they started with very small bays and working up, but it allowed a conversation about why something may have been omitted or what other options there could be. Because obviously you talk and you clearly explained how sometimes it can be the pharmacological omission or sometimes the mechanical. Have you found that there is a difference in a gap of understanding and learning in that what options there are and how these are best offered to a patient for them to understand? Or do you think there's more training of staff that needs to go on about the wider options that are available, whether one isn't suitable or whether there's a patient refusal?
I will say that especially in our trust, the health professionals are quite aware of the chemical and mechanical means of prophylaxis we have to offer, and they are aware to whom they have to offer them. Like for stroke areas, the nurses are well trained and they know that once a patient is diagnosed with a stroke, immediately they will measure and they will apply the IPC. And we are fortunate that nurses are able to prescribe mechanical prophylaxis as well, which is really good. They are able to prescribe, apply, and observe them, and it's all electronic. Yeah. And we're able to collect data from that as well. And in other areas, like in all medical areas, they know and they are aware now that are not using anymore the anti-embolism stockings because of the clots trial and everything. And they're aware that the most appropriate prophylaxis is the chemical prophylaxis for their patients. Now, the other thing about chemical prophylaxis where we have a bit, where we lack, and I think it's not just us, but it's you can find that in other trusts as well. Sometimes we don't give enough information to the patients, because when we're talking about low weight molecular heparin, we're talking about an animal derived product. And there are a lot of people that may say, you know what, I'm vegan, or because of religious purposes, I don't want to have that. And there is where we will be able to come in and say, you know what, fair enough. We have other products that we're able to use instead of the low weight molecular heparin. Maybe there it's where we need to teach more our staff about what other options we have apart from these two medications, apart from the low weight molecular heparin, sorry.
That's okay, thank you. And as you mentioned, you do have nurses who can prescribe both chemical and mechanical thrombophlebitis.
No, they only can prescribe the mechanical. Sorry, they only can prescribe the mechanical. Chemical prophylaxis is only prescribed by doctors.
Okay. Have you noticed, and this is one of the questions come through, have you notice any compliance difference in patients who are offered a mechanical prophylaxis? Do you know, is there any data to show if that's sometimes a conversation that is more compliant with anybody unable to take or not appropriate to have chemical thromboprophylaxis?
Can you repeat this question?
Yeah, sorry.
Sorry.
The question was, and it come through, was have you, when you're looking at reasons for refusals, is there a better compliance with maybe mechanical over sometimes rather than chemical, or is it about the same?
No, it's about the same. It is about the same. Yes. Yeah, it is about the same. But as I told you, because we usually use mechanical prophylaxis, and I'm talking now about the intermediate pneumatic compression devices, the IPCs, in stroke units, neurosurgery units. And we usually, because the staff there are well trained, they are able to give all the information to the patient and their family, and they are at some point, yes, they are willing to have the compression devices on them.
Yeah. Thank you. There's a lot of questions coming in around VTE audit tools and how often you collect them. So what VTE audit tool do you use and how often do you collect the audits? Are there ward VTE champions to support this as well?
Yeah. So we are collecting the VTE data in cooperation with business intelligence unit. So as I said, we are fortunate to have our VTE risk assessment electronically. So BIU is collecting the data for us once a month, and they are sending them to us. So we're able to filter them out, and we can find exactly we can produce the scores, and we can produce figures for each area, but for the trust as well. And at the same time, we have the link, the VTE champions in each area, which they collect data and they produce audit for their area separately. And on those audits are more detailed on what kind of medications they're using, on the omissions of medication, if that was the correct dose they used. With more detailed data we have from the nurses' audits.
Okay, wow, thank you very much. And then there are questions coming through as well. I think a really good point made by a Ruby in the audience, who said in their trust, the ambulance staff weigh the patients on arrival to A&E, and they weigh the patients, however, with their bags on the bed. So the wrong weight is often recorded. From this, it shows that there would be a good idea if some education is given right from the start, from the ambulance staff right the way through. Have you noticed this, or is there any program in your trust that looks at the whole spectrum of the journey for that patient through VTE and the training of the staff?
Well, we are in cooperation with learning developer nurses of all the areas, and we did manage to achieve and the pharmacy teams as well, and we did manage to achieve to wait patients on their arrival to the hospital. To be honest though, I was not aware of that situation, waiting a patient on a bed with all the equipment and everything. I was not aware of that. But yes, if that is happening, that's something we need to highlight it for future reference.
When you've been setting up this and your VT assessments as well, how have you brought on board the mixed teams? Because obviously, such as that scenario, then hearing from different individuals, you will get pictures of some very easy to address but important to address errors going on, as well as more complex ones. How have you brought on or engaged with people involved, with all of your staff?
So we are here at the King's, the thrombosis department is really good cooperating multidisciplinary team, and we have people that are really engaged with VTE prevention. And as I said before, we are the first VTE exemplar center, and we're really proud for that as a trust. And we are able to communicate any issues we have with all levels in every area. We are able to communicate it with consultants, we're able to communicate with matrons, we're able to communicate with managers. So everyone, and because everyone are familiar with the national guidelines and the national requirements, they are all engaged and they're all helping to improve our assessments, our VTE risk assessments, and our VTE progress in all departments. We never had issues. Yes, there may be some areas with issues that we're trying to improve, but they're all open for discussion. And we're able, because we're able to collect data, we're able to show them what is happening at this time with your area comparing to other areas that are following those protocols, and what we can do together to improve the figures, the scores, or the practice of any area. It's all about teamwork. It's all about teamwork.
And in that team, have you been able to bring on, say, the medicine safety team, so there's wider teams as well, or the preventing harm team, maybe in the management of the admissions and things like that?
The harm-free team is engaged to any of the issues we're coming across, especially if it's a hospital-associated thrombosis and a root cause analysis needs to be completed, and obviously an adverse incident will need to be reported. Then we will go and work together with the safety team as well.
Thank you. Now, something you mentioned about, and obviously it comes into NICE guidance, and it was also in the GIRFT report, was around patients being given information, written or oral information.
Yeah.
This is very close to my heart. But equally, I appreciate, and I'm sure everybody else does, how busy all staff are, and the pressures on them to share lots of information and do lots of things across the whole disease areas. So yes, I mean, and thank you for sharing the Z cards. We've got cards, and I know many trusts develop these. I'm aware that King's is in the process of making a new film for patients around blood clots and blood clot prevention. It looks really exciting and worthwhile. But are there other ways, apart from sort of the handing, of ways you can gradually feed in information when you have the opportunity? How would you advise staff on that?
So obviously the best way to continuously feeding information is when we are actually offering them the thromboprophylaxis. Is that 1 minute, 2 minutes that takes for us, for the nurses to prepare the chemical prophylaxis and go to the patient to give them the injection, just to let them know. It's just few words. Just say, the reason I'm giving you this injection is to protect you from developing clots. And it's nice to know that if you go home, you may develop some soreness on your legs, some soreness on your redness or swelling, or maybe some shortness of breath. It's nice just to give them some more information. I think that it doesn't take more than a minute. It doesn't take more than a minute, that's where I try to engage nurses more into that. It's not about the leaflets. Yes, they're amazing. They're doing a great job. And we're thinking about like posters as well in discharge lounge rooms or in corridors where the patients are sitting and they're able to see them, or some QR codes where they can scan them and go directly to videos and stuff. But I think the best way is to actually tell them few things, why that you need to give them the injection in the tummy, or why do you need to have the sleeves on their legs.
I think you're exactly right.
I think that's the best way to do it. And it doesn't take more than a minute, maximum 2 minutes, if they have questions about it.
I think you're exactly right. I think that drip conversation going in, it's personal, it's one-to-one, very relevant to them and very, very reassuring, I think. And that is what makes the difference. Moving on just slightly to a question from Rebecca about what do you find is the biggest challenge in ensuring high quality risk assessment? Because having a risk assessment tool is one thing, but ensuring high quality risk assessment, obviously another.
That's obviously one of the issues we're coming across, and it's exactly what I said at the beginning. We're trying to teach people that VTE risk assessment is not just a ticking box. It's not a ticking box exercise. It's important to complete the VTE risk assessment correctly, because a correct VTE risk assessment will guide the prescriber to decide what the appropriate prophylaxis will be for their patients. And at the same time, if a VTE risk reassessment needs to be done, or if the patient for some reason comes back into the hospital, we will be able to compare the two. We will be able to see if we missed anything the previous time. Are we missing something this time? And it does help us a lot when we're running root cause analysis for any hospital-associated thrombosis. A correct VTE risk assessment does help us understand more about the patient, because obviously we don't always know the whole background of the patient, as we're not, unfortunately for me, I'm not clinical, so I don't know the whole background of the patient. So a correctly completed VTE risk assessment will be amazing, but unfortunately we don't always get that.
Thank you. And again, in your scenarios, Ruby has asked, some patients are very complex. So if somebody came in with a history of stroke, but is admitted for a hip fracture, how do you weigh up what is the best thromboprophylaxis to provide for this individual?
So obviously, if we're talking about a patient with a history of stroke, and it's had a history of stroke a month ago, 2 months ago, 3 months ago, that patient can still have chemical prophylaxis, because we're talking about an old stroke. The chemical prophylaxis, according to the guidelines, is only contraindicated for acute stroke patients. And if I'm not mistaken, I don't want to go into stroke nurses and stroke consultants fields, it's supposed to be, we're not supposed to offer any chemical thromboprophylaxis to acute stroke patients within 14 days of the stroke, because it can cause hemorrhage. But after that, it's safe for the patient to have chemical thromboprophylaxis, and always after a VTE risk assessment.
Okay, thank you. Moving on to a person being discharged from hospital, are there recommendations or what guidance do you use locally for follow-up after hospitalisation with an individual with a high risk of VTE or bleeding compared to those with low risk? Because they may go home, they may be more mobile, but they may not be. How do you help manage, or what continues then when those, how do you discharge those patients?
Are you talking about extended thromboprophylaxis?
Yes. Yeah.
So extended thromboprophylaxis, again, we're following only the NICE guidelines. Extended thromboprophylaxis will be given only to patients following hip or knee replacement, or other surgical procedures like obstetrics, or women that had previous history of DVT or PEs during pregnancy or cancer history, and they will be offered some extended from prophylaxis after giving birth or after caesarean section. But anyone else that is discharged from the hospital, ideally they should be given some information on signs and symptoms of VTE while they're at home, and for at least for some advice for early mobilization, advice for well hydration, some exercise when they're home, and just to inform their GP or visit the emergency department if they develop any symptoms of VTE.
Great, and thank you. And then there's another scenario, which is, you can probably see this one, about in a centre where a foot surgeon has requested that the day surgery patients are given a dose of low molecular weight heparin prior to discharge. They don't stay in the centre for very long, a couple of hours, and there is some uncertainty about whether they should start on injections at home to reduce the risk of post-op bleeding rather than there. What guidance do you have on this, or do you work from? It's a complex.
So it is a complex one, as there are no guidelines regarding that. And if there are, I'm not familiar with that, but it's a consultant's decision. So obviously, if a consultant decides, and all prescriptions are consultant decisions, medication doses and stuff are consultant decisions, as far as is prescribed and is signed, then, and is a consultant decision, then we can obviously come confront them, have a discussion with them. If we have evidence that, you know what, the practice you're using is not helping the patients, but it's increasing the bleeding risk, then I think that's a local matter that they should assess in that area. And I don't know if that makes any sense, but if it's a consultant decision, obviously we can't say much about that.
No, that's. And then you've obviously implemented from 2007, King's has been an exemplar centre. How do you sustain the ongoing training and improvement, especially as obviously teams change, but also locum staff are in, and then we suffer pandemics and pressures and burdens of work, just the volume of work. How are you sustaining the high levels of VT risk assessments and appropriate management of patients?
So as I said, we are a multidisciplinary team. We are trying to have regular meetings with other areas, and especially with areas with lower figures of VT risk assessments. We're trying to make people aware of our existence, just to alert them and let them know that we're still here, we're still by your side, we're working with you, and let's improve whatever we can, however we can. Let's find ways to improve our practice. And to be honest with you, we had, even during COVID, I will say that we have a really good cooperation with all the areas. And their numbers on VT risk assessment were even more improved during COVID, because people were so engaged it was something new. So everyone was so engaged to do the best possible for our patients.
Thank you. I think that's just what, everybody working in the NHS and in healthcare are there to do the best, aren't they? And it's sessions like this that are so helpful in sharing and exampling how that can be attained. We're actually at our time. We've had a huge number of questions, so thank you so much. Some were very complex, but thank you so much, Loizos, for your presentation, for your answering the questions and your time today. And thank you to Cardinal Health for sponsoring this symposium.